nationally, internationally known medical oncologist in melanoma who really has done a number of important pioneering studies in the area of biochemotherapy. He's in Los Angeles, and we've worked very closely together over the last 10-15 years, sharing a lot of patients in what we like to call our corridor from LA and San Francisco. And he really has, I think, a very unique perspective on treatment of advanced melanoma. And so without further ado, Stephen ODay.
Well, thank you, Mo, for that kind introduction. Can everyone hear me in the back? Okay, okay. Well, I'm delighted to be here. I just want to also thank Valerie for putting these symposiums on. We did a very successful one in Los Angeles. I know she's going around the country, and she's really pioneered the advocacy and really energized us. And as you can see, she also helps the melanoma researchers get together and communicate and share data. And all of this is really a very exciting time in melanoma. So what I really want to do today is I'm going to focus, some of my slides are somewhat repetitive of what's been said, so I'll skip through those more closely. But what I really want to give you all a feel for is that this disease has really exploded in terms of our scientific knowledge. And as Dr. Kashani told you earlier, the work the pioneering work they're doing in terms of analyzing the genes of the primary melanoma to make sure that we have a proper diagnosis, and then to give us some assessment, a better assessment of is it going to spread in the future, is critical, because then we can start to stratify patients for new therapies, the high-risk patients, but spare patients who really should be cured with their initial surgical treatment, side effects from treatments they may not need. So it is critical that the diagnosis is made correctly, that we know what we're dealing with, and also then we have a good understanding of what this person's risk profile is in terms of developing metastasis. And then the third area that he talked about really is then now personalized therapy. How, if it does metastasize and spread, how do we treat that patient more uniquely as opposed to just based on their tumor? And we're starting to develop what he mentioned as predictive markers. And the BRAF gene is one example of that, where that will predict who will respond to certain new treatments. But it really is a brave new world. There's going to be a lot of data coming out in the next 2 to 6 months, and we are making progress. So I think the message has to be, even if you have stage 4 melanoma today, this is what you can be cured of your disease, and certainly we can now start to extend your life meaningfully, and by bridging you and keeping stage 4 patients alive, they're going to have opportunities to get access to the new drugs, and the new drugs are coming fast and furious. But I can tell, because our waiting room, we have a very busy melanoma program for 15 years. We sort of had a steady state in the waiting room, because obviously people die of this disease, unfortunately, and then we get new patients, and we sort of used to have a steady state. Now the waiting room is swelling, and it's because people are not dying of stage 4 nearly at the rate that they were before. And I think that's just an amazing story, and it's going to just get better in the next few years. So this has already been talked about, but this is the fastest rising incident cancer over the last 20 years. Worldwide, there will be 132,000 new cases and 66,000 deaths in 2009. And in the US, 68,000 new cases and about 9,000 deaths. And your chance of getting melanoma, if you're a male today, is 1 in 39, and female 1 in 58. And the key with this disease, obviously, as Mo talked about, obviously early detection and early treatment before the melanoma starts to get into its vertical growth phase, where it can spread, is key. But like Dr. Miners talked about, millimeter for millimeter, this disease has the propensity to spread much more than any other cancer. And of all the skin cancers, obviously, basal cells and squamous cells, which are vastly more I think melanoma is 4% of all skin cancers diagnosed, but in terms of deaths to skin cancer, it's 80%. So obviously, it can be detected early and cured, but if not detected early, it can spread quickly. And this just shows you over this epidemic. It really is an epidemic. Between 1935 and 2000, you can see your lifetime risk is now 1 in 74 in 2000, and it just shows you that's going even higher. But what makes this disease different than many other diseases is that it hits people 2 decades before most of the major tumors of aging, and that's breast cancer, lung cancer, prostate cancer, and colon cancer. The average age of onset for those is really 65, 70, but in melanoma it's 40 to 50. So obviously it can be much younger. I see teenagers and young adults. So it's really hitting people in the prime of their lives, and it's a very serious diagnosis. So obviously the lost life years are huge in terms of its impact. I'm not going to go over really the ABCDEs of melanoma, but I think that the only thing I want to say is not all melanomas follow a textbook. And the other important thing is that less than half of melanomas actually arise from an existing mole. So any new lesion on the skin that is changing and growing should be biopsied and evaluated. Because I think some people get the sense that if it wasn't a pre-existing mole, it couldn't possibly be melanoma. Certainly, there is a situation where moles change into melanoma, but actually the more common scenario is for a new lesion to develop. And having lots of moles is really more of a, what we call a phenotypic, it's a risk factor in general for developing melanoma. But we shouldn't just be concentrating on the moles. It's the skin in between that's even at higher risk. Now in terms of risk factors, personal history, obviously if you've had one melanoma, you're at much higher risk for a second melanoma in your lifetime. Family history is important, although it's still a relatively small subgroup of patients that have a true genetically inherited melanoma. If you have lots of moles that are atypical, again, that's an increased risk of developing melanoma, but all your skin's at increased risk. Sun exposure is the one thing that we have some control over, but it really is your 80% of your total sun exposure in your lifetime is by the age of 18, unless you work outside. So obviously it's our children, and teenagers, young adults, it's that extensive sun exposure that 20, 30, 40 years later may set you up. So sun is important. But if you're 75 and you have melanoma, you don't have to be too worried about the sun at that point, is my point. And the reason for this is in the 1900s at a typical beach, and you can see how people dressed then, and this is nowadays. So obviously, sun worshiping has been a major contributor to the rapid rise, and tanning beds are even worse. In terms of just a couple things about sunscreen, because this comes up, sunscreen should not be used to prolong your recreational sunbathing. It's just false sense of security that if you're using sunscreen, you can stay out longer and not have the risk. So basically, you don't want to get burned. And the problem with sunscreen is people continue to go out at peak hours and then don't reapply accordingly and get burned anyway. So it really should be used as an adjunct, but not as a primary means of avoiding the sun. It really comes down to avoiding direct exposure to sunlight, wearing hats and protective clothing, avoiding the midday sun, and sun lamps and tanning beds are probably the worst. And obviously, frequent skin exams are very important. I'm not going to go over the staging because that's what Dr. Miner did for us, but I'm really now going to concentrate on stage 4 disease. I just want to make one comment that comes up all the time. If you have a level 4 melanoma and a stage 4, it's very scary because the level 4 relates to how deep your primary is. It's called Clark level, and we measure thickness in both millimeters, but also an older way of looking at it was layers of the skin. So you can have a very early stage melanoma that is a level 4, but people then go to the computer and internet and they translate that to stage 4, which is completely different. So I just want to be sure you understand that distinction. Stage 4 means it's spread through the bloodstream out into the internal organs of the body. Level 4, Clark level, relates to levels of the skin where the primary tumor is. And within stage 4, which is what we're going to talk about now, there are 3 categories of melanoma: M1A, M1B, M1C. So M1A is the most favorable, and that means it's moved to other areas of the skin or other lymph nodes that are not directly related to the primary. So let's say you had a primary on your arm, but you got a subcutaneous nodule in your skin in your left leg. Obviously, that's not a lymphatic, that's a blood-borne metastasis. So patients who have distant skin involvement from the primary site or lymph nodes are stage 4, but that's the most treatable stage of stage 4. Now, stage 4B means it's gone to the lung, and for whatever reason, lung is a slightly better site to have a metastasis than any of the other internal organs, lung, liver, and brain. And I think it's really important. One of the values of being at melanoma centers of excellence with doctors who really treat this disease is there's a lot of biology to melanoma. Some melanomas are very fast growing at multiple sites right from the get-go. Others may just have one slow growing tumor that you can surgically remove and may do well for a year or two. So there's a vast spectrum of what we call the biology of disease. And when I put together a treatment plan with someone who comes for stage 4 melanoma, I'm really concentrating on understanding the biology. How long ago did the primary take effect? I mean, did you have a lesion on your arm 15 years ago, and now, 15 years later, you have a single lung metastasis? That's a completely different biology. That means it's been dormant for 15 years, your immune system is pretty good. For whatever reason, it allowed one tumor to grow 15 years later, and that can be removed surgically as the best treatment, and watch, because you could go another 10 years before you develop another melanoma. Now that's the exception. The more common presentation, once it spreads to stage 4, is that there are multiple tumors and that they're relatively fast growing. But the doubling time of the melanoma on average is 30 days, but we have people who have doubling times of over a year. And obviously, how you approach those cancers is much different. So how fast is the tumor growing? And is it spreading to new sites, or is it just sort of growing at the existing sites? That's very, very important information for me to try to put the best plan together. And obviously the sites of metastasis, where it actually is critical. Obviously if it's in the skin or a lymph node, that's one thing. If it's in the lung, that's sort of intermediate. But if it's in the liver, bone, or brain, that's a more serious site. But a lot of thought needs to go into the natural history of how you got to stage 4 melanoma. And I spend a lot of time in that first half hour of consultation trying to understand the biology, and I think it leads to much better treatment decisions. It's difficult because patients, when you have that diagnosis, you feel like you have to get treated like yesterday. And what I guess I'm saying now that we have all these new genes and everything, there really needs to be a period of time where we can study the tumor genetics, the biology, and put together the program. Because it's going to work just as well in a few weeks as it will the day I see you in terms of whatever program we have. Now, Dr. Miner talked a lot about some of these standards. My job today is really going to talk about some of the new stuff that's coming down the pipe. But like we talked about, there is no standard treatment for stage 4 melanoma. It depends on all the things I just talked about. Yeah, surgery may be an option. It may be the best treatment for someone with a single lung metastasis 15 years after their original primary. Chemotherapy has just not been effective, unfortunately, by itself. this tumor is very resistant. But I'm going to show you some new ways that we're trying to attack and make chemotherapy work better. And this has crippled us a little bit because most other tumors, breast cancer, others, get a lot of mileage out of chemotherapy. But in melanoma, we really have been crippled with the inability to find effective chemo drugs. The upside is we've had biologic therapies. These are the kind of things that Dr. Miner talked about, interferon and interleukin-2. These are very powerful immune stimulating drugs. And unlike other diseases, melanoma has a relationship with the immune system. The problem with high-dose interleukin-2, as David described, and high-dose interferon for a year, is that they're non-specific immune stimulants. It's like releasing a nuclear bomb, and there's lots of collateral damage. The hope is we'll kill the melanoma in between, but there's a lot of sacrifice that comes from that. And so intellectually, it's been very unappealing. And in terms of side effects and quality of life, it's been unappealing. And the actual number of patients that benefit from these broad biologic immune stimulants is very small. And we can't really predict who they are. So that's sort of so it's sort of like you've got the atomic bomb, you're trying to get the Taliban, you know, and you're going to destroy most of the city and country. But a few of these treatments clearly cure, you know, 5 to 10% of patients. And, you know, certainly they're in our armamentarium. Now, the last thing here, biochemotherapy, is something that David and I have worked together over the last 15 years to develop. And this, again, is like the kitchen, throwing the kitchen sink at it. 3 different chemo drugs, plus interleukin-2, plus interferon. We've made it more palatable, but it still requires coming to the hospital for 5 days every 3 weeks. And those two of those 3 weeks are pretty miserable. Having said that, about half of patients will have major responses, and anywhere close to 15 to 20% will be cured with that approach long term. So it is in selected cases where patients really need a quick response and their tumor's growing very quickly. That is one option that's going to remain on the table for us, and it can be quite effective. We are also using that approach for high-risk stage 3 disease in some patients. If you have multiple lymph nodes, you're young, you're at an 80% risk it's going to come back. Getting the biochemo earlier may be effective, and there are studies comparing biochemotherapy to interferon. So let's talk now about the brave new world that's here now. What's in the clinic right now? So I just told you that chemotherapy is not effective by itself, but we've come up with, there have been 2 recent studies we've done at our center that have tried to get around the problem of chemotherapy. The first is a drug that's now on the market already for breast cancer called Abraxane. And this is a drug, Taxol, that's very common, used in lung cancer, breast cancer, number of different, ovarian cancer, number of different. It's probably our most active single chemotherapy drug across a lot of tumors. But what's different about this is that it's put into a little albumin sphere, a little protein sphere, and the drug is put inside. And the way it works is these little spheres can then leak, they preferentially go to the tumor site because the blood vessels around the tumor are leaky. And so these little spheres leak out of the blood vessels into the tumor site, and then the sphere disintegrates and the chemo is released. It's sort of like a Trojan horse analogy. And the tumor cell, normally these little protein or albumin spheres are how cells get nutrients into the cell. So there are receptors that actually grab these little spheres and bring them into normal cells that need nutrients. Well, the cancer cell gets faked out because it thinks it's a nutrient, but within it is the Taxol chemotherapy. So that's one drug that looks like it may be our most active single agent. And unlike other chemotherapy drugs that seem to only work 10% or less of the time, this drug seems to work about 30% of the time. And some of these responses can be long-term responses. So it's an exciting new drug that's in, and we're using it now. The other approach to chemotherapy is chemotherapy damages the DNA in the cells. And there's a repair mechanism by which all cells repair the damage to the DNA. And a cancer cell has a set of enzymes that can quickly repair the damage to the chemo and preserve the cancer cell. But we now have a new drug, an oral drug called a PARP inhibitor, that actually blocks those critical repair enzymes. And so it makes the cancer cell more vulnerable to the chemotherapy. So the chemo will do its damage, and normally in melanoma, chemo doesn't work because they have this highly developed set of enzymes to repair the damage quickly and the cell survives. But if we take out those repair enzymes with a second drug, it may make the chemo drug work better. And we just completed a trial with an oral chemotherapy drug, Temodar, which many of you may have been on or heard of, with a second, this PARP inhibitor, and we're seeing some good responses. So in terms of chemotherapy, we're developing strategies to get the chemo better into the cancer cell through a delivery system. And then we're also trying to figure out how to cripple the resistance mechanism of the cell once the chemo hits. And so this just shows you, this is the Abraxane drug, and you can see it's here, these albumin spheres, not really spheres, but you can see the yellow, and then you got all these little Taxol drugs in the sphere, or within on the surface of the sphere. So these little spheres that are moving around the bloodstream, and they're just big enough to leak out into the tumor blood vessels, because the tumor blood vessels are very leaky. And then these are the spheres that the tumor cell thinks is nutrients, and it's bringing it in. And then these Taxol, the chemo drugs, release from the albumin sphere. So it's pretty cool technology. Taxol is the first drug that's been put in this model, but theoretically you can put any drug or any biologic agent in these little spheres. And then this is just a diagram explaining what I was talking about PARP. This is probably hard to read from the back, but in the center of it you can see the DNA being split, and then there's this whole set of repair enzymes that zipper. It's like a zipper that's been undone and then zipping it back up, and we're blocking that zipping back up. And so that's another way to go. So chemo, even though chemo has a bad rap in melanoma, I think it is important that we get it into our options, and we're just going to have to be more sophisticated about how to use chemotherapy. It's not the answer in melanoma, but we really haven't had any benefit from it. But what I'm trying to say now, we're starting to figure out ways to make even chemo-resistant melanoma sensitive to chemotherapy. And if that happens and it starts to break up the tumor more, it will make it more vulnerable to the immune system, etc. So let's just talk a little now about the immune system, what we're trying to do. So there are basically, well, I'm going to describe three cells, and Dr. Miner already talked a little bit about this. There's three important cells of the immune system. One is this dendritic cell, or what we call antigen-presenting cell with the tentacles. This cell is in our skin, and they move around throughout the body. They pick up little pieces of viruses or bacterial things or little pieces of tumor. And what their job is then to bring that piece of tumor, in our case, back to the T cell. I'm going to describe, so there's two types of T cells. One is a helper T cell, and then the bottom one is the cytotoxic T cell. And it's the job of these dendritic cells to bring bits of tumor to the T cell, and they have a relationship, and it shows the T cell this and says, look, this is formed. You need to kill it, because T cells can kill things. If they're viruses, they're very effective at killing viruses. They're not as effective about killing tumor cells, but we're going to show you how we're working on that. So those are the three types of cells I'm going to be talking about. So here just shows you an example of this, where the dendritic cell has picked up a piece of tumor or whatever virus, and now it's having a relationship consummated with this T cell that's attached to it. And that consummation generates what are called helper T cells, and then these cytotoxic T cells below, you can see in the green. And these cells then, you can see the tumor way to the right. Then these activated green cytotoxic T cells then release interleukin-2, and then you can see attack the tumor. So interleukin-2 is an important cytokine that sort of gets in the dialogue and communicates between these cells. But the problem with interleukin-2 we talked about is it sort of just causes a huge immune storm. And I'm going to show you how we're going to get around some of the side effects. Now, Dr. Miner talked about high-dose IL-2, very toxic. The biochemotherapy has interleukin-2. A third way that interleukin-2 is being used is where we actually take, Dr. Rosenberg at the National Cancer Institute, you can take a tumor, and within a tumor there are T cells. You can pull out those T cells, genetically modify them in the laboratory, and give them back to the patient with high doses of IL-2. And that's what's called adoptive T cells, where you're taking your own T cells out, making them super T cells, and then giving them back. The problem with that approach is it's very time consuming. You have to get the tumor, remove it. It takes months to get ready, and many patients don't have that amount of time to get ready to get treated. So there's a new approach, and that's called targeted IL-2, and then we also have T-cell targeted therapy. So these are the new sort of elegant T-cell approaches that I'm going to talk about. So I'm first going to talk about IL-2 targeted therapy. So just like the little spheres where the chemotherapy is delivering the chemo directly to the tumor and not causing a lot of side effects at other sites of the body, interleukin-2, wouldn't it be nice if we could get, instead of giving people massive doses of interleukin-2 and making you really sick in the ICU, what if, couldn't we get the IL-2 and target it directly to the tumor environment? And we're just open to study. It's called ALT-801, and this is really cool. This is it's a molecule that, I'm going to show you a diagram after this, but let me just walk you through the steps. So this molecule goes to your spleen where you have many T cells. And the ALT-801 has an interleukin-2 segment, and then it has a separate segment that's directed at the tumor. So the IL-2 portion of the molecule binds to the receptors displayed on the surface of these T cells and natural killer cells in the spleen. So this molecule goes into your spleen and grabs the T cells that are important and turns them on. And then it carries them with it to the tumor site. So here's the diagram. You can see all the way on the left, the effector cell is the T cell. Okay? And you can see the little green sphere here, and that's where it's going into the spleen, and it's hooking on to that T cell. And then you can see the red part of the antibody is what it's dragging the effector cell. It's dragging the T cell to the tumor because there's a p53 marker on most tumors, and so it's basically dragging that effector cell, and then the red part of the molecule is hooking up with the tumor. So by bringing these killer T cells to the tumor site, it can then lyse the tumor. Because a lot of times people's tumors somehow manage to nuke the T cells that come after it, the tumor. And so sometimes when we take people's tumors out, they have no T cells in their tumor. Whereas other people have lots of T cells. Now obviously the people who have T cells in their tumor generally do better because it means that their immune system is actually able to fight. But in the patients who don't have that ability for whatever reason to get their T cells to the tumor, here's a way to pick them up in the spleen, bring them literally to the tumor, and then releasing it. So amazing technology with a molecule that has two ends to it. One that's latching onto the effector cell, and then one end that's targeting the tumor. So this is a way to bring IL-2. Normally, we have to give massive doses. Here, you can give much lower doses because you're bringing the IL-2 right to where it needs to be in the tumor environment. Similar to what we talked about with those bringing chemo to the little spheres to the tumor site. So the benefit of these new elegant therapies is we're bringing these toxic drugs right to the tumor, and likely they will be better served there with less general side effects. And we don't know that for sure yet with this drug, but we're in the process. So this is going to be an IL-2 program that we have now that's going to be given with chemotherapy. So it's sort of like biochemotherapy, but it's in the outpatient clinic. So you don't have to come in for 5 days, you don't have to be in the ICU, you're just going to get this 3 times a week. So whether it will be as good as IL-2 in the hospital, we don't know, but we're hopeful. And I think it could be better if it's really bringing the molecule to where it needs to be. So I think that's really exciting. The next area is not bringing IL-2 to the tumor site, but what David talked about with this drug, ipilimumab, but actually manipulating the T cells to then kill the cancer. And I have some nice cartoons here. So on the left is this dendritic. Remember we talked about that dendritic cell that has a piece of the tumor. These are the cells with the octopus arms. You can see on the left there's a light blue antigen on the purple receptor there. So that's the primary receptor where the octopus dendritic cell brings, interacts with the T cell. That's the consummation. And it has 2 steps. The first part of the consummation is it will latch into this T cell receptor, okay? And when that's done like this, you can see that gives a positive signal to activate the T cell. So normally your T cells are quiet, just hanging out. You get a virus, or theoretically a tumor, hopefully. These octopus cells grab part of the tumor, grab part of the virus, they bring them in, lock into this T cell, and that's signal number 1. Now it turns out, when a major breakthrough in immunology, early in my career, mid-90s, Dr. Lee Naber at the Dana-Farber in Boston found out that there was a second signaling component to this. So if you had this first signal, that was not sufficient to really send it off. There was what's called a second signal, and that's the B7, which is present either on the tumor or the antigen-presenting cell that's bringing it, and you can see CD28 is its co-receptor on the T cell. So after the first signal is hit, you need the second signal, and when that happens, you see a second signal. Now the T cell's totally turned on. It's activated. It's a super T cell. It's ready for action, okay? Now, as David said, you don't want your T cells just to be firing nonstop. They will get exhausted, they'll commit suicide, and it's like a stress, like my 17-year-old daughter in the middle of all this AP stuff. They're overstressed. So the T cell, we would not want to burn out all of our T cells. And with viruses, you pretty much can clear your virus within 5 to 7 days. So there needs to be an off switch so that your T cells don't stay on and start to do damage where they shouldn't be on normal tissues. So that's where this CTLA-4, this important break to the immune system, to the T cell, comes into place. So once the T cell's turned on for a period of time, it should have done its job. Now it's got to turn itself off. And the way it turns itself off is it brings the CTLA-4 to the surface of the T cell. And it just so happens that the affinity for this CTLA-4 in red to B7, its ligand on the other side, is much stronger than the CD28 interaction. So by doing that, it steals the B7 from the CD28, and that gives the negative signal, and the the T cell then quiets down. Now the idea is that it goes into a memory phase, and if you have a virus in the future, you've got all these memory T cells ready to go back into action. But that's the normal, appropriate thing. The problem with cancer is much more difficult than a virus, and it finds ways to nullify the T cells. And one of the ways it does it is through the break here. So we need to find a way to not allow that break to come into play so that the T cell will stay on and keep going after the tumor. And that's what the antibody does. So here's the antibody, you can see, and the antibody blocks the brake. So by blocking the brake, you're keeping the accelerator down. Sort of like Toyota on the left lane of the I-95 or whatever. You know, you want your T cells going out of control on the fast lane looking for tumor, and that's exactly what happens here. So let me just recap. So in terms of how do we make chemo better in 2010, we can devise ways to put chemo in little spheres and get it to the tumor. We can also find ways to prevent the DNA enzymes from repairing itself, and therefore that will make the chemo work better. In terms of the immune type treatments, the interleukin interferon, what we're going to do is we're going to bring IL-2 directly to the tumor, cause a lot less side effects. Hopefully that will work as well, we'll know. But even more important, instead of adoptive T cells, we have to take your T cells out of your body, like Dr. Rosenberg's doing, tease out the T cells, modify them, give them back. We can do that in your bloodstream just with the CTLA-4 by blocking the brake and creating an army of T cells. And that's why it takes that particular treatment 12 to 24 weeks to work. Because you're not targeting the tumor, you're targeting the T cells and building an army and then letting them go to battle. Now, one of the side effects of that approach is by keeping those T cells turned on, obviously, they can start to recognize your own tissues as foreign and start to attack your own tissues. And many of you who've been on IPI, that's the reason for the rash and for the diarrhea and sometimes the liver problems and the pituitary problems, is because the T cells are so turned on and they're out of control. They are going after tumor, but they're also finding normal tissue and sort of getting into trouble on the side. Now, the deal is we want some of that to happen because when you get rash, when you get some diarrhea, that suggests that we have the immune system at a good state. But obviously, we don't want it to get out of control or for you to perforate your colon or anything. So at the beginning, we were afraid to treat those side effects with steroids because normally steroids will reduce the immune system. And we thought it would make the melanoma grow faster, but it turns out now that you can treat the diarrhea and the rash and others with steroids for a period of time, and the anti-tumor effect will keep going. So that gives us the ability now to sort of manage the side effects quickly and not feel like we're gonna lose control of the T cells fighting the tumor. So it seems like once the T cells recognize the tumor, they're resistant to the steroids. But the T cells that are looking at your own tissues, they seem to die when the steroids hit them. So it's a very interesting evolving pattern. But that's just the first T cell antibody, and now we have 4 or 5 other of these T cell antibodies that both push the accelerator and block the brake. And it'll be very interesting to see how those treatments go. But so the immune area in biologics is really, really advancing quickly. The last area I want to just talk about is angiogenesis. Tumors require blood vessels to grow and spread. And they release substances to make these blood vessels so that it can grow and spread. And there are ways to obviously block the growth of these new blood vessels. And so there are drugs already on the market. One of them is called Avastin, where it soaks up this VEGF in green is one of these molecules that stimulates new blood vessel growth. So this antibody Avastin basically just locks up the VEGF, and by locking it up, the tumors can't make new blood vessels. If you can't grow, a tumor can't grow unless it both gets nourished and it makes its own blood supply. So this has been a very important drug, and in 2009, in combination with chemotherapy, we appear to have some very promising data in melanoma. And now we are combining this drug Avastin with the drug Abraxane, the drug that has the little spheres with the tax on it. And the combination, my partner, Dr. Boasberg, presented last year, looks very, very exciting. So it's clear that we can deliver the chemo better to the tumor. We can make the immune system rev it up and target the tumor, and then we can starve the tumor of its blood supply. And we can theoretically start to do all three of those at once, so the tumor is really going to be unable to spread and grow and create problems. And just last, I don't want to talk a lot, but it's already been briefly discussed. There's what's called pure targeted agents. So it's not chemotherapy, it's not immune therapy, it's not starving the tumor of the blood supply. But this BRAF pathway is a very critical pathway that allows cancer cells to grow, multiply, and divide. And we now, about half of melanomas will have a mutation in this gene. And if you have a mutation, there's some new oral drugs that are called BRAF inhibitors, and we're seeing dramatic responses in more than 70% of patients who get this drug. So this is a whole new area of looking at genetic pathways that's very different than chemo, that's different than the immune system, but again, may also work well together. So in summary, I hope I can give you hope that, number one, this landscape is dramatically changing. 5 years ago, we basically only had IL-2 and biochemotherapy, and those still have a place. I'm not saying they don't, but now we have better ways to deliver chemotherapy. We have much more sophisticated ways to manipulate the immune system without making somebody horribly ill. We can starve the tumor of its blood supply, and we can target certain genetic pathways. So it really is personalized therapy. What Dr. Kashani talked about in his third thing, predictive markers, we're going to be able to interrogate the tumor for c-KIT and BRAF, and there's a whole slew of other genes. And then we're going to be able to look at your tissue types, called HLA, and then we can put the best program. But all that has to be combined with the biology of the disease. How many sites do you have? How fast are they growing? All this is a very complex sequence of decision making, and that's where centers of excellence really are needed. So, I mean, anybody can give the drugs per se, but I think the real expertise is to have dermatologists, surgeons, medical oncologists, radiation therapists working in centers of excellence devoted to a disease, and it's really, and then having access to these cutting-edge clinical trials. And once we start doing that, then I think we'll start to make a huge change. So my motto is cure if at all possible, and we are actually curing people with stage 4 melanoma now. And but if not cure, at least prolong their lives in a significant way with less side effects, and ride the wave to the next new breakthrough. And the breakthroughs seem to be coming every couple months now, as opposed to every couple of years, because people are working really diligently on the scientific end of melanoma and our clinical end. So there's lots of resources that are going into this disease. So I think I'll stop there and appreciate your attention.